You want to get her in the picture? Just tilt over a little bit. There she is. Okay. So come on back and let's zoom in on the x-ray that you're seeing. This patient we're about to do surgery on has already had a surgery on his lower back. It was done years ago. I did not do it. I can't take responsibility. I would not do this type of work. In my opinion, the screws are too skinny. I always use thicker screws, and I always use a cross-link in the lumbar spine. Now, what's interesting about this is that this patient has cages. There's a cage right there, and there's a cage right there. And this is an older style of surgery because he actually has two cages, one there, and they were put in, one on the left side and one on the right side. And we call this a PLIF, P-L-I-F, as opposed to a T-LIF. So PLIF was the original posterior lumbar interbody surgery. It was done by making a bilateral laminectomy and putting a cage in on one side and then moving the other nerve root over and putting a cage in on the other. So you did two cages and you got bone graft between them. We don't do this kind of surgery anymore because it's more invasive and unnecessary. We just put a cage in from one side nowadays. That said, I didn't do this, but I would have used a cross-link. So that's L4-5 he's had surgery at. He now comes in with adjacent segment disease below, and that's right here at L5-S1. And we're going to go in and fix L5-S1. So let's bring our camera back over here. Sir, it's Dr. Deuk Majin, okay? We're going to get started. You lay still. Now, this would be a good time to give him a little something to calm him and ease him up with pain. Maybe a nice little sniff of some fentanyl. Now, you're going to feel a little stick and burn, okay? I'm putting some numbing medicine under your skin. You don't have to nod your head. You just lay still. If you feel discomfort or pain, say, ouch, okay? But don't, I can hear you, but don't move. Okay. All right. You ready? You're going to feel a little stick and burn. That's normal. That's just the medicine going in, okay? So don't be upset. Give it a second to work. I know it's uncomfortable. I apologize. If you want to get angry at anybody, get angry at the anesthesiologist, not the surgeon. It's not my fault you're feeling pain. I may be the one instigating it, but the perception of pain is cortical. And he's in charge of your cortex right now, not me. All right, I'll give you some more numbing medicine, okay? But just lay still. Don't try to come up off the table. You're doing great, by the way. Everything's going well so far. Yeah. A little bit lower than I need to be. Blood pressure good? 115? Oh, 150. No, we need to get it down. I don't know what I should, you know, I mean, it's the same thing every time. We just got to, it's like racing a car around a racetrack. You got to hit your marks. The marks don't change. It's the same. The track may change, but you have to hit the apex every corner. Those apexes are the blood pressure and the level of comfort, movement, things like that. All right, let's get an AP. And let's go lateral, figure out where we are. So we're aiming for the disc below the fusion. Remember, I didn't do the fusion. The fusion was done many years ago. How long ago was your spinal fusion? 9 years. Huh? 5 years. Ooh, somebody did a PLIF 5 years ago? That's interesting. Where was it done? Huh? All right. So you're all the way to the ground? Good. And you're going to need to go north just a little bit. See how you're seeing a little too much of the hip? Just a little. Where was it done? Honestly, didn't understand that. All right. Did you raise the bed? No, she can't go up. She needs to go down. Put your floor to the ground, please. Don't listen to Luis. Only when he's right. All right, so we got an issue. The bed is not rising. Why is the bed not rising? Is it not plugged in? Hello, we need your help. That's usually the reason it won't work. So, fun in the operating room. Again, I'm Dr. Deuk. We're at Deuk Spine Institute. We are performing a Deuk laser disc repair, endoscopic surgery. Now that it's plugged in, can you raise it? Can somebody sing Zippity Doo Dah for me, please? There we go. That's good. That's good. All right, he raised it. He raised it. All right, let's get a shot. All righty then. All right, so now your job is to help me get that. Since we're doing L5-S1, do you see the disc? It's actually pretty good where it is right now. Honestly, look at it. It's pretty good. You know what I mean? You want the end plates lined up. But you all can see the screws that were put in at L4-5, and the disc below is the one we're aiming for. That's the one we're going to fix today, L5-S1. Just lay still. You're doing great. That means shot, by the way, in case you didn't know. Shot? All right, so I'm up against the facet joints. I need to wrap around them a little bit. Shot? You're doing fantastic. Let's hope we don't have the same issue we did the other day. Shot? Huh? All right, we need to rotate a little like this, orbit, just a little bit, like a degree. That's way too much. Why would you do that? What?
As soon as I unlocked it, that's what blew up, so it could be on the arm over there.
There's no way it's on the arm. His arm's in a surrender position. What are you talking about? You may be on a cable. I need you to get me that lateral view. This is time to put your big girl pants on. Your prime time. There it is, right there. That's pretty good, right there. I like that. Lock it in. So do you see how the end plates at 5-1 are good? And there's really the sacrum and everything's looking lined up nicely. All right, so I've tried. Where's our blood pressure? Where's his blood pressure? I need to hear from you. Okay, shot. That's okay. All right. What's the problem? Everything okay? So here's what I'm going to do. I'm just going to come out for a minute till you get that blood pressure under better control. You doing okay, sir? Just take your time. Let's get it right. No problem. Just take your time. Like I said, I want to get the blood pressure down. You understand why the blood pressure needs to be down? Yeah. And there's two areas the blood can go that concern me. One is epidural, and that's a surgical emergency. The other one is intramuscular, which means pain and suffering for weeks and weeks after surgery. And both of them I want to avoid. 145 over 94. It's coming down, but I'd like you in the 120s. That's some progress, maybe? Okay. Well, we're not worse. Right? I'm just trying to be positive. Do we have any questions from our audience? So for those of you who don't know, this is Dr. Deuk at Deuk Spine Institute. And we're going to be performing not an open surgery, but an endoscopic surgery. This patient's had an open surgery already. And many people have fusions. There are 1 million fusion surgeries done a year in the United States. Most of them are on the lower back, the lumbar, like this gentleman had done. About a third of them are on the neck. 2/3 are on the lower back. But that's 1 million surgeries that are unnecessary. because we don't need to do fusions anymore. We have the endoscopic Deuk laser disc repair, and that will fix about 98% of patients who need fusions. The other 2% I can't do for various reasons. We had one like that last week. The patient had very large facet joints, which are in the back of the spine, and they were blocking the needle from getting into the disc. And I can't do the surgery without the needle getting into the disc first. So we tried different entry points, we tried different trajectories, we tried all kinds of stuff, and I could not get the needle into the foramen and into the disc where the herniation was. It was impossible. I was being blocked by the giant bony joint that was literally about 3 to 4 times bigger than it was supposed to be because of arthritis. The other problem the patient had was his spine was extremely deep. What deep means anterior. Anterior means towards the front of his body. In other words, it was away from the back. The more anterior the spine is towards the floor, the harder it is for me to reach it, because you have to have a certain angle that you approach it. Like I'm limited to how far lateral I can go to enter and start. I can't go past the curve of the back. And basically I'm going at 45 degrees, but if the spine is further anterior, I got to go at a steeper angle. And that means the facets are more likely to block my trajectory. So we just had a patient who had big facets with a deep spine, and that combination led to me not being able to access his discs at L4-5 or L5-S1. So we're going to be converting him into a fusion surgery. And we'll probably do his fusion surgery in the next couple of weeks, as long as his insurance approves it. How are we doing on blood pressure? Huh? If you want to give some propofol, put him to sleep for a few minutes, and then wake him back up when I'm going in with a needle. I mean, I'll let you play with what you need. But basically, I just need that blood pressure in the 20s or lower. And and I need him comfortable, so when I start going in with the needle, that he doesn't start squirming around like a fish. Problem is, if the patient's real uncomfortable as you're putting the needle in, he's going to tighten up his muscles. He or she, of course, will tighten up their back muscles because it hurts, and then that will divert the needle's trajectory. It'll literally shift it away from where I want to go. Are you awake? Yeah. Good. I'm trying to go in through an old hole that I already made, giving him a little bit of medicine. I'm giving you some numbing medicine, okay? You feel that? All right. Yeah. Trying to make it more comfortable for you. Shot? All right, so I'm a little more north than I want to be. Let's head back south towards the feet. Shot. I'm aiming for that foramen at L5-S1. Shot. Right on the facet joint, as you can see. Need to get around it. Shot. Just lay still. You're doing really good. Are you awake? Shot. Well, I was close. He's got an interesting, he's got a high iliac crest. Shot. 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 It's just too high. Take that. Where are we at blood pressure wise? Give me local.
We have a question.
Sure.
A viewer on Facebook is wondering, why does the patient have to be awake for this part?
Because if I touch their nerve with a needle, I want to know. And there's no way to know unless he tells me. And there's no way for him to tell me if he's asleep. Does that make sense? I hope that does, because that's the answer.
And another question from a viewer on Periscope who's wondering, regarding bleeding, what's your protocol for someone who's on Xarelto?
Xarelto. So for this type of surgery, we still need our patients off Xarelto. If you're somebody taking any kind of blood thinner, you need to come off. Generally with Xarelto, it depends on why you're on Xarelto, the cause for needing it, but generally you want to be off for 5 days to 7 days. All right, let's get another shot. 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 Well, now we're on track. Nicely. Yeah, we're right there at the facet shot. And we're lining up nicely with the disc. Is he okay?
All right?
Shot. We're very close. Let's get an AP and see where we are in the AP.
You okay? Yes.
Yeah? Are we good?
Yes.
A little faster. All right, not bad. All right, let's go back to a lateral, please. All right, so we're just on the outside of the facet joint. We're very close to where we need to be. I just need to make some minor adjustments to the trajectory of the needle. Everything starts with the needle positioning. I have to get the needle right, shot. If I don't get this right, then the surgery doesn't work. There we go, shot. All right, are you pulsing? That's perfect. Are you awake? So this is where I need him awake. Just let me know if he's awake enough. Just, no problem. Take your time.
Can you hear me now? Okay. Are you awake?
Just give him a minute.
Yes.
You think he's reliable?
Are you having any pain?
Did he get propofol?
You got 20 mics.
Just lay still, Fentanyl.
20 milligrams. No, you don't fit in the head. 4 verse.
4 verses. So how long do you think till I can rely on him? Few minutes?
You shake your head. Are you okay? He says he's great.
Oh, all right. You have any pain back here? Okay. I'm in the foramen, shot. I'm right at the back of the disc. So I'm right on the herniation at this point. I feel a little bit of resistance. Let's get an AP just to make sure everything looks good. When you're doing this part of the surgery is called navigation. Just like a captain in a ship navigates from one port to another port or one location to another. You get out there in the open ocean and you're trying to go from a starting point to an ending point. Literally, that's perfect, lateral. You're going from a physical point to another physical point. So if you think about the tip of the needle being the ship, I have to navigate the ship from the outside world, a starting point, which is variable. I could start anywhere I want to start, to an ending point. The ending point's more important. The ending point must be where the tear is in the back of the disc. That I don't have any control over. That's a very defined physical address. So I need to go from the outside world to there safely through waters that are safe. There's no coral reef where I could wreck my ship on. I can't really see very well. That's better. Again, somehow he's moved and we're off a little bit on the arc. So maybe either drop your side and see what happens or raise it, one or the other. I don't care. Probably drop it and see what happens. Just a degree. That's better. That's good. Let's just leave it there. Are you comfy? He's awake now. I can see him responding. Are you comfy? Sean?
Are you hurting?
Are you okay? That shot could be a little better. Give me another. All right, so there's the needle. Okay, it's in the disc. at 5-1. Is he awake and reliable? So I want the patient to be awake at this point because I've actually navigated from the outside world, the skin entry point, which is right here. You see that, Sean, right there?
Yes, we can.
So this is where we start doing our drawings. I started doing this lately, and I think it's very helpful. So let's talk a little bit about him while he's waking up. Can you guys see the back here pretty good?
Yes,
All
we
right.
can.
So I'm gonna mark his old scar. You got time, don't worry. We got a few minutes of teaching going on here. That's his old scar. All right, that line I just drew right over the scar. I could see the scar underneath the drapes. So his surgery was done 5 years ago, the fusion at L4-5. And what the surgeon did was he took the bone out and then he put a cage right here. That's a cage. You see it on the x-ray. Then he put another cage here. And this is inside the L4-5 disc. So there's one vertebrae right there. That's the number 4 vertebrae. And then there's another vertebrae right here. That's the L5 vertebrae, okay? Those are bones. And they clean the disc out between and they put the cages in, one on the right, one on the left. This is the right side of the patient. Okay, this is the right side, and over here is the left side. Now, he's got a problem at the disc below. That's the L5 to S1 disc, okay? And that's what we're dealing with now. This is the sacrum. Okay? And here's the disc that's damaged right there. You see that? Now that's not it right there on the surface, it's underneath. But he's got a little tear in the back of the disc like this. See that little tear? And the jelly from the center has squeezed out like that. And I put my needle into that because it's deep inside. And we're going to use the laser to repair the tear and the herniation. Is he awake?
No, can you speak up?
Are you awake?
No.
Hey, you doing all right?
Can you speak up? Can we hear you?
You doing okay? Is that a yes?
He said he's awake.
Are you comfortable? All right, so I want to know if this disc is the cause of his pain. I want to verify that. Not getting a very good injection shot. Shot. I just can't get any of the material out. I think I'm too close to the end plate, which is not good for the injection, but it's okay for the surgery. Huh?
He's in a little pain.
You feel something there? Is that where you typically have your pain? Literally, just must have junk in there. Let's try the pipe cleaner. Just see if we can't get this shot. Now, some of these discs have a lot of scar tissue, so they don't pressurize well. It's not common. Shot. Starting to get a little bit in there. Could probably come back even more. Oh yeah, just hold on now. Who'd you come here today with? Who'd you come with today? Yeah. Yeah, I just literally cannot get the dye to come out. Weird. Huh? You felt it? Is that where you typically get your pain in your back? But is that the area, that area? Okay. I mean, I would just say poor filling, very poor filling, but concordant. But I don't think we can get a reliable score. All right, you can go to sleep. When you wake up, we'll be done with your surgery, okay? That disc must be full of scar tissue. Nope, everything's good. You just go to sleep. I want you to count from 1 to 100 for me. Shot. Can you do that? Count out loud for me. Keep going. He's only one disc, right? Yeah, so he has a fusion at 4.5, and then he's got a bad disc above at 3.4, but I don't think he has pain up there. When he told me he had pain, he said, my pain's right here. He literally pointed to the 5.1 disc. I said, what about up here at 3.4? He said, nope, don't have any pain up there. So we're only fixing the herniated disc that's causing his symptoms. If we were just fixing every herniated disc he has, we'd be doing like almost his whole spine. But there's no point to do that because he's not having pain up here. When you have pain from a herniated disc, the pain the patient has, the worst pain is always right where the disc is. They can actually point to it. It's amazing. And we use that information. That's almost more important than an MRI scan. The MRI doesn't tell you where pain comes from. It just shows you structural abnormalities. So when you line up their pain on exam with the MRI findings, you can figure out which discs are causing the problem. Shot? So we're heading down to L5-S1. You could see a little bit of dye in there. I couldn't get very much out, and I'm not sure why, but I think it's the disc is so full of scar tissue from chronic inflammation. If I had to guess, that's what I'd guess right now. I haven't seen a lot of those. It's rare for that to happen, but it can happen. And personally, I think that's what's happening here. Shot? So I'm coming up to the back of his disc right now. I'm in the foramen, just sneaking in underneath the L5 nerve root as it exits. And I can feel the herniation there, shot. So we're going to go in to the disc at this point. Yeah, I'm going to try to advance it over the guide wire so I know we're going in the right place. Shot. Yeah, I pulled the guide wire back just a little bit. Shot. The patient needs to be asleep for this part because it's very painful. Shot. Yep. And he's asleep, by the way, in case you're wondering. L5-S1 is one of the hardest discs to treat endoscopically with the transforaminal approach. Many surgeons that do endoscopic surgery, there's not a lot of them, by the way, but the ones that do around the world, a lot of times they don't even try to do L5-S1 transforaminally like I'm doing. They try to go basically interlaminar. They won't even go with this approach. Shot. They're going to take the lamina out. Shot. Good. Shot. All right. So we're in. And basically this is the smallest surgical incision you can make to do spine surgery. All right, pull your fluoro out. There is no smaller incision. This is it, folks. The only thing smaller than this is a needle. And we're not doing needle surgery. We're doing real spine surgery. Oh, I don't know. Did you all see the drawings?
Yes, we did.
All right, good. Okay, yeah. So, putting on the fluid adapter. I don't use suction on the tube while I'm doing this. And we're ready to get started. Okay, so we're going to bring in the endoscope. The endoscope is a skinny metal tube that goes down the tubular retractor. It has a system of lenses that allow light or the image of what's at the end of the tube to be displayed on a camera screen through a camera. The camera is actually attached to the back The blue is the disc. We're inside the bad disc, the damaged disc. We're not going to remove the whole damaged disc. I'm just going to fix the part that's painful. Okay? The blue dye stains to degenerated nucleus pulposus. Nucleus pulposus is the hydraulic jelly that God created in all of us and put in the middle of our disc. And that jelly is surrounded by the annulus fibrosus, which is not a hydraulic jelly, but a containment system for the hydraulic jelly, made out of very dense connective tissue. Okay? Now the annulus fibrosus is devoid of blood supply in the inner half of the annulus fibrosus. So no blood supply, no innervation. It's just totally inert. On the other hand, fix it. Sorry, the fix it was not part of my dialogue with you, the audience. It was my team. Did you show her what you're talking about? So it's exactly as I said. This is very scarred, very densely scarred. I need about 10 minutes, we'll be done. I'm telling my anesthesiologist. Dr. Pettit, 10 minutes. There's the tear right there. That's what's causing all the pain.
We have a question from the audience.
Of course. Be happy to take the question. Before you ask the question, let me just do a public service announcement, okay? A PSA. You know, when I was a DJ in college at UC San Diego, I would have to do public service announcements in between the music that I played. They were called PSAs. Because we went to a public school, UC San Diego, University of California, San Diego. We had a public radio station. I have an FCC license for broadcasting, and I used to have the radio DJ show. My first show was 4 to 6 in the morning. Oh yeah, you want to be a DJ, huh? You got stuck with the worst hours. And of course, once you get some seniority there, you get better times, like the 2 to 4 show. That's 2 in the morning, folks, not 2 in the afternoon. I used to wake up, splash some water on my face, get on my bicycle, and bike down to the radio station because I lived on campus, and then I would do my show for 2 hours. And a public service announcement was basically just that. You're announcing some event or entity or whatever. So we'll do a PSA because we're doing broadcasts for free. This is educational. And the public service announcement is this. You're watching live spine surgery from Deuk Spine Institute. This is the annular tear, by the way, with the jelly stuck in there. And that's what I'm here to fix. Deuk Spine Institute broadcasted surgeries live every week with the consent of our patients to broadcast. We don't provide you with any identifying information, so it's HIPAA compliant. Many of our patients agree afterwards to do videos to let the rest of the world know how they're doing, share their experience, so others can learn from them. We're able to cure back pain, neck pain, and thoracic pain at Deuk Spine Institute. About 98% of the pain on average for each person that has pain. Now, Deuk Spine has a Facebook support group. If you're on Facebook and you want to join our support group, it's free. Go to the Spine Surgery Support Group on Facebook. Spine Surgery Support Group on Facebook. And just ask to join the group. The only thing we ask is that you don't be a robot and you don't spam or fish on our website, we're not there for you to come and advertise your product, but for you to share your experiences and to help those who are suffering. You don't have to have spine surgery to go to the spine surgery support group. It's really just a support group that's designed to allow people to have an open, free exchange of ideas and information related to back and neck pain. Also, if you haven't downloaded the Deuk Spine Institute app on your phone or computer, it's free. We developed the app last year, and it has a lot of very useful information on the app, including testimonials, and you can also submit an MRI for a free review at Deuk Spine to see what we would recommend for treatment if you're having a problem with your spine. Okay, we don't charge. It's free for the review. We also do free telemedicine. So if you're somewhere in another country or state and you want to know what can we do, what can be done to fix your problem, if anything, we're happy to do a free telemedicine Skype call after you send in your MRI so I can look at it and figure out what's wrong. I personally do every one of those telemedicine visits at this time in 2021. That may change in the future as I get busier. But for now, we offer it for free for anyone suffering because we want to help people. I don't think anyone suffering with chronic back or neck pain should have to suffer without knowing that their pain could be fixed and how it could be fixed. All right, there's my PSA. Now that I've said that, what is the question?
So, let me see here. The question coming from a viewer on YouTube is wondering, is military neck an actual condition that people are born with?
All right, I heard about it, 50% of what you just said. Is a military neck an actual condition? Is that what you asked me?
Yes, and what does it mean?
Uh-huh. Well, so let's talk about it. Is there a disease condition called the military neck? The answer is no. And if there is, I honestly don't know what it is. There is a military posture, and that is a posture that we want our patients to have. It means a straight, you know, when you do the military salute, you pull your head back, you straight up, eyes on the horizon. That's the posture we want all of our patients to have in their neck. It's called the military salute posture. But there is no such thing as a military neck that I know of. Now, what they could be referring to is injuries to your spine, but there's no such thing as a military neck diagnosis. No. It would just be the same things that everybody else has, which is degenerated disc, herniated disc, bulging disc, ruptured disc, annular tears, spondylosis, stenosis, radiculopathy, myelopathy, kyphosis, scoliosis, listhesis, all the usual things, including osteophytes. So those are the true diagnoses, and a military neck may just mean somebody whose neck's been messed up in the military, but the mess up part is the same as everybody else, which is those adjectives and words I've just told you. If you want to know more about your neck condition, get us your MRI and send it in to Deuk Spine. We'll do a free review. We'll let you know what's wrong and what needs to be done to fix it. Okay? This patient, like I said, had a fusion. I didn't do the fusion in their back. Someone else did. And we're fixing the disc next to the fusion now, the L5-S1. Okay? Because that's where his pain's coming from. And I believe his pain is going to be 100% gone after the surgery. And we're going to check on him in about an hour from now, okay? As a matter of fact, our first patient we just did, posterior cervical laminectomy fusion, may actually be awake in an hour from now. I'm just giving Dr. Pettit a hard time. That's right. Yeah, he's catching up on sleep he hasn't had in years. So we're just about done. Dr. Pettit, 1 minute. I'm done, 1 minute. You guys hear me? I'm done in 1 minute. This is pretty much it right here. And then let's get this patient to recovery, and we'll get this patient home in about an hour from now. What time is it right now? Don't give me military time. 3:33. So hopefully this here patient is going to be ready to go in 4:30. About the time we'll be getting done with our next surgery. What is the next surgery, by the way, for our audience? Oh. 3-level lumbar. Left 3-4, right 4-5-5-1. All right, there you have it. So our next surgery is a 3-level lumbar. We're going to go at 3-4 on one side, at 4-5-5-1 on the opposite side. So we'll be making incisions on both sides of the back. 30 seconds, we should be done. Very, very scarred up here. Very scarred up. Let me have a grabber. Take that. It's going to take more than just a minute. Give me another 2 minutes, actually. There's more herniation here than met the eye. Look at that. A little bit of epidural fat there at the top. That's that billowing pillow of adiposity. No big deal. We're not here for the fat. I'm here for the tear underneath the fat. Any more questions, Sean?
We do have another question. A viewer is wondering, do all surgeons keep patients awake during the first part of the endoscopic surgery?
All surgeons don't do endoscopic surgery. The question was, do all surgeons keep patients awake during endoscopic surgery? The answer is, there's probably only 50 surgeons in the world that do endoscopic surgery. In the United States, there's probably less than 10. So, do they keep the patient awake? Honestly, I don't know. Everyone's going to do things a little bit different. But the surgery you're watching here is not done anywhere else. Sure, endoscopic surgery is done elsewhere, but not the Deuk laser disc repair. This is a very unique surgery. So the way I do things is not, you can't assume that other surgeons do the same thing. Sure, every surgeon makes an incision, but where they make the incision, how long it is, how deep it is, what they do after they made the incision, that's really highly individualized based on what the surgeon does. I'm done. Laser off. It's a fair question, but I just don't know what other surgeons do. But I can tell you the chance of nerve damage would go up dramatically if the patient was asleep. And it's a risk I wouldn't want to take, no matter how good I was. Of course they're having 10 out of 10 pain because they've had Narcan. All right, let's take a look here. I want to show you all the incision. Has the last patient gotten all their oral pain meds? Who's caring for the last patient? You want to bring Ann in here? Actually, I'll just go out there in a minute. He needs to be taking all of his normal pain medication. Yeah, I understand. All right, let's show the audience the incision. Sean, can you see this?
Yep, we can.
So we did the whole disc repair. Now, mind you, the fusion he had done was for the same reason I just did the laser surgery. Back pain coming from the L4-5 disc. We just fixed L5-S1 with this 7mm incision. No screws and rods and no fusion. Pressure. So much better surgery to do the laser surgery over a fusion. Okay, I've got a Raytech off. Thanks, everybody. I'm going to go check on our last patient. A what?